Good morning and welcome to the HIV Prevention England conference. It is so wonderful to see you all here today, gathered from all around the country, here with one goal in mind. Before we get started, there's some important things I need to say. There is no fire drill planned, but there are fire exits for those who might need them. They're either side of me and head backwards behind me if you are heading out, but obviously we are hoping that will not be happening. Importantly, please do not consume nuts in the building. The aircon is so good you might kill someone, so please don't make sure that happens. And if you do have dietary conditions, please do let our team know, and they will ensure that they are catered for throughout the event. So thank you for being here and gathering at the HIV Prevention England conference. It's something that we as Terrence Higgins Trust are proud to be part of, to lead and to share with the sector. It does such important work in ending new cases by 2030. So we have 5 years, 3 months and 24 days if we're to meet that goal of ending new cases by 2030. 5 years, 3 months and 24 days if we're going to be the first country in the world to meet that goal and end the onward transmission of HIV. 5 years, 3 months and 24 days if we're going to be the first time we've ended the onward transmission of any virus without a vaccine and without a cure. That's not long to go. We know there's a lot of work to do, and we have to have the determination to make it happen. We're looking for 4,500 people in England that are living with undiagnosed HIV. There's 14,000 diagnosed people with HIV who aren't taking their medication because of stigma, discrimination, racism, homophobia, transphobia, poverty, and much more besides. They must be high in our minds. And for those that are seeking out HIV prevention, it has never been more scarce. Condoms are at their lowest spend in the country's history. We have a 12-week wait on average to get PrEP if you're in a category that is, quote-unquote, eligible for that drug that could change people's lives. There is lots to do and determination in this room to do it. Impatience and pragmatism. I think that's how we feel as a sector. It's my approach running the Terrence Higgins Trust, and I know for many of you it's the same. When we work in HIV, we have that passion for our cause and that drive for equity. But if we're honest, it's a little frustration too. Too often we meet people where their HIV acquisition could have been prevented. We know it, we see it. Too often we meet people where their diagnosis could have been earlier, and had somebody done their job properly, it could and would have been. We see people who could and should be getting their care, but the barriers we put in their place are what's holding them back, not them and their lives. And we want to take a very different approach to making that happen. Today is delivered by those people who've bottled up that frustration and turned up to those meetings, not with all the lists of things we can't do and why it's too difficult, but the people who say, let's try something new. Let's listen to service users. Let's try and try again. And I think that is what is so remarkable about the DNA of people who work in this sector, that determination to get it right and make a difference. Today has been made possible by an excellent team at HIV Prevention England and support from the wider team at Terrence Higgins Trust. I want to single out Thomas, Nicola, Joe, Barry, Brogan, Taku, Caroline, Eugene and Dominic, all of which are people who work with real endeavour and skill to make not just today happen, but testing week and the year-long work that HIV Prevention England does. I also want to thank our HIV Prevention England activation partners who do amazing work and support that happening, all the speakers that you'll hear from today, and of course, importantly, our lovely sponsors at Gilead, Vive and Pasante. We couldn't do this without them. We are lucky in this field to have amazing civil servants, and not all virus and health advocacy groups can say that. But with Adam, Olivia and Bav, we are lucky to have allies on the other side of the table, fighting our corner when the doors are closed. I think you'll join me in thanking Professor Kevin Fenton for not only the work he does day in, day out in his day job, but the extra work he does leading the HIV action plan and making sure stuff happens. He is definition of swan-like. Whenever you see him, he is cool as a cucumber. Nothing is ruffling those feathers. But underneath, Those legs, those legs are powerful, and they are making that power known. And behind those doors with ministers, we know he is not just persuasive, but encouraging of them to be bold and take more action. Finally, I want to pay tribute to those living with HIV. It is absolutely remarkable that in the prevention of the onward transmission of HIV, those living with HIV continue to take a lead, have the highest ambitions for our sector and the work that we are doing. If you look across the programme, there are people living with HIV on so many of the sessions, sharing not just their lived experience of living with HIV, but the work they do in this sector and that learnt experience to make sure their experience is not the experience of those who come after them. That, I think, is pretty amazing, and we are really in their debt. But if we're going to end new cases of HIV, it's really about leadership. We know we have all the tools possible. We could have done it yesterday, but if we're going to get it done by 2030, it's about convening all of the strands of work that we know are necessary to make that happen. And we have the determination to do it, but others have the power to make it happen. And the role of government has never been more important. As we get closer and closer to that goal of ending new cases, the role of those political leaders is important. And I want to thank the last government for the work that they did and the way they listened to us time and again on a series of issues, not least finding the funding, not just once but twice, for opt-out testing in our A&Es. We've seen how effective it's been in Brighton, London, Blackpool, Manchester, and now finally Salford. And we've seen how that has found people and re-engaged people and made a difference. Getting that extra funding to see it rolled out. And just this week, Birmingham started doing opt-out testing in their hospitals, and we know others are joining with it. We couldn't have done it without their leadership. But you'll know that the 14-year trial on whether you spend lowest amounts of money on prevention might lead to higher or worse outcomes has come to an end, and some things have changed. You'll notice there's been a change in government. And we are lucky to have at the helm somebody who has spoken often about our cause in Keir Starmer. We have Wes Streeting as the Health Secretary, who has not just been a service user in our area and talked openly about some of these issues, but was a member of the HIV Commission himself and is probably more prepared on HIV than any other virus or healthcare issue. But we also have the most remarkable friend in the Public Health Minister. Andrew Gwynne has shadowed this role and its surrounding roles for a number of years, to great frustration, because it's never good having to have that shadow before your title in work. But he has been unleashed and is now the Public Health Minister. And we are really lucky to have a friend, somebody who's been consistently an advocate for our work, here with us today and speaking to you, but more importantly, leading this issue. Now, you have to promise me something. Do not let him leave this stage unless he promises a new HIV action plan and a way of sorting out the 1990 plan. Andrew Gwynne, over to you.
Thank you, Richard, for that kind introduction. Andrew Unleashed. You've been warned. And that's just for the civil servants. Look, I want to start by paying tribute to the fantastic campaigners in the audience. The Terrence Higgins Trust, the National AIDS Trust, the Elton John AIDS Foundation, and so many others. Who went to Pride this summer? Put your hands up. Yeah, I went to Manchester Pride. I was invited by the brilliant George House Trust to march with them and their team and their float. And for me, I got giddy because I got to march with Russell T Davies as well to promote their undetectable equals untransmissible message. I have never felt prouder of my home city. I saw things that made my heart swell. Families and children, old people, young people, ordinary Mancunians supporting fellow Mancunians and having fun along the way. I saw other things as well, so ask me about that over a drink a bit later. But anyway, one of the perks of being a minister, dropping that shadow after 14 years, is decorating your office with the government art collection. And when I asked my team if there was anything there, and they showed me the catalogue, and it was all boring artwork. And then I was offered a portrait of a young man. The artist has sketched his bare chest and shoulders in deep red pencil. Your eyes travel upwards to the subtle details of his face. Two other figures, faintly sketched either side, look straight at you, holding your gaze. These are the 3 Ages of Terry by Curtis Holder, perhaps the most famous sketch of the great Terrence Higgins. And I love this portrait. Look, scrub what my script writers have said. Your eyes gaze up and you actually wander to 2 nipples. It's not the 3 Ages of Terry, it's the 2 nipples of Terry I'm gazing at. But it's not the original. The original is in the National Portrait Gallery, and MP's salaries certainly don't stretch that far. I didn't put it there to match my carpet. It was a lovely gift from Richard and the Terrence Higgins Trust at our first meeting. The first meeting that I had with external stakeholders was with THT, the National AIDS Trust, and the Elton John AIDS Foundation, and I hope that reassures you of the priority I give to this area. But I love this portrait because of what it represents. No, not nipples. It reminds me about everything I want to achieve in government. No, not nipples. Look, for the avoidance of doubt, the new Public Health Minister certainly does not have a nipple fetish. Can we get that out there? Back at a time when AIDS was still called the gay-related immune deficiency, it was the THT, founded by Terry's friends, Martin Butler and Rupert Whittaker, who wanted to put a face to unseen suffering. The lives ended too soon. The families bent in grief. The communities ripped apart. These friends achieved that and more. They raised awareness of HIV, reducing the pervasive stigma around the disease. They raised millions of pounds for research. They put the UK on the path to ending HIV transmission once and for all. Curtis's portrait that hangs in my office reminds me every day whom I'm there to serve. The consequences of inaction, and what we can achieve when we work together. For me, it is a symbol of my long and proud history with the Trust. You have meant something to me my entire political career. As a councillor, an inspiration. In opposition, a friend. In government, a loyal partner. So now, as Minister for Public Health, with me and Wes at the helm, you will have no stronger allies in the vital work that you do. I want the bonds we forged before I was in government to become the bridge today that connects us to the communities we serve and helps us move forward together. I know you will do the hard work on the ground, holding me and the government to account when we fall short. Hopefully we won't. And pushing us to go further in our mission to end new transmissions in the UK by 2030. So from me and every member of the new Labour government, thank you. I also want to say thank you to the team behind HIV Prevention England. And in particular, I want to mention the brilliant Dom Edwards, who has worked on HIV Prevention England and its predecessors for 25 years. He's not just a director at THT, but a stalwart and a beacon for what people living with HIV can achieve. So Dom, a big thank you. Give him a round of applause. Now, as Richard said, After 14 years in opposition, I'm keen to make up for lost time. In the Labour manifesto, we committed to launching a new HIV action plan, and that is what we will deliver. We are working with you and with others to publish it by the summer of next year, and I have made it clear that it must follow some very clear and key principles. Firstly, the plan must ensure equal access and uptake of HIV prevention programmes, giving vital information to those who need it the most, and in making sure that everyone who should take PrEP, that game-changing drug, can access it free of charge on the National Health Service. Because, as I said at the start, the consequences of inaction are far too great. Secondly, we must scale up HIV testing in line with national guidelines. That means we must test, test, test. Now, I know the data, the figures, show that we're going above and beyond the UN's 95, 95, 95 target. And look, we should be proud of the progress that we've made. But I also know that data doesn't actually show the complete picture, because it doesn't always capture people who are not retained in care. And it's important that we don't rest on our laurels of that published data, which doesn't give the clear, true picture, because we don't and can't let anyone with a diagnosis slip through the cracks. So I have asked my officials to review how we measure those performance indicators, and I pledge to you this. Later this year, we will publish new data that takes all of this into account, so we get the correct picture as we head towards HIV 2030. And look, credit where it's due. Those who remember me in opposition will know I don't always give credit to Conservative politicians, but I salute the last government for introducing opt-out testing in accident and emergency, because it's not a party political issue. We supported them in opposition as they moved this forward. And I've always worked with people on all sides of the political aisles to get stuff done. That one decision to expand opt-out testing has probably saved more than 1,000 lives in its first 2 years alone. And not to mention identifying thousands more cases of hepatitis B and hepatitis C by testing people, including heterosexuals and men who have sex with men who don't identify as gay or bisexual, who never even thought they were at risk. So our action plan will build on that success. Thirdly, we must improve the quality of life for people living with HIV and wipe out the stigma they still face. Just 2 years ago, Positive Voices found almost half of the HIV patients that they surveyed felt ashamed about their diagnosis, and 1 in 25 had been verbally harassed for being HIV positive. Let me be clear. It is now this government's position that one person getting verbally abused is one too many. That's why it's so important to smash the stigma in society for people who are HIV positive. Yes, we've come a long way since the 1980s, but let's be honest, there's still so much more that needs to be done in this area. Finally, and I think above all, I want a plan that reflects people. That means listening to people and understanding their needs. Every HIV patient, every person is a unique human being with their own wants, their own needs and agency. And our plan must reflect that. That same survey by Positive Voices found almost 92% of patients were satisfied by their treatment plan. But we need to help the 8% who weren't satisfied. So I've been clear that to make this plan a success, we must tailor the system to suit every patient. In other words, we cannot pigeonhole patients into a system. The system should fit around the needs of the patient. And I want closer ties with civil society, supporting them to deliver this real change. Whether that's with the Terrence Higgins Trust, the National AIDS Trust, the Elton John Foundation, or many partners across local government and every one of the organisations in our community advisory group. I want all of you to help us shape our action plan, because we each of us have our part to play. Public and private, business and voluntary organisations. Together we can turn the tide against prejudice and deliver lasting change, like those pioneering heroes of the 1980s. 2 weeks ago, I was proud to march alongside some of them at Manchester Pride. I thought about how much we all owe to those brave men and women, some of them still with us, others not, who started organisations like the Terrence Higgins Trust. As they pass on the torch to a new generation, let's live up to their legacy. And I look forward to beginning this new chapter of our story together. Thank you very much.
He did good, no need for the heavies to keep him on stage and make those key announcements. Andrew, thank you very much, and it is an honour to have you here. And also, apparently this is your first conference and your first big speech as a minister, so we are really proud to have you here and to host you in that way. So thank you very much, and thank you for the work that you will do over the coming years for us. Next up, we've got somebody who doesn't need any introduction to this audience, but Professor Kevin Fenton is a friend, an advocate, and somebody who is fighting for us in public and behind the scenes to make this action plan happen. You'll know he's the Director of Public Health for London, but also he does many other things, including recently becoming the President of the British Association of Science. So congratulations on your new appointment. I hand over, and if you can greet in the normal way, lovely Professor Kevin Fenton.
Good morning, everyone. Good morning, everyone. Morning. Right, we need that energy. The minister has given us so much energy this morning, and I need you to keep that energy today. Because the work is hard, the work is long, but we are doing this work together. So colleagues, this morning I have the privilege of sharing with you my experience of supporting and leading and championing the HIV Action Plan. And I want to begin this morning by thanking the Terrence Higgins Trust, our colleagues in HIV Prevention England, all of the partners who've worked with us over the past 2 to 3 years on the HIV Action Plan. And I'd like to thank you. Your advocacy, your voice, your persistence, your challenge makes a difference. Promise me you will never be silent in the face of injustice. And promise me you will not be silent as we move towards our ambition of ending HIV transmission by 2030. So this morning I wanted to do a little bit of reflection, and I was really pleased to see that the theme for the conference is focusing on health equity. Many of you know that whether in my work on HIV, my work on COVID-19, my work in London, health equity is a key part of what we do in public health and what defines our work in public health and what will define our work on ending HIV transmission by 2030. And I'm going to begin with a little bit of Public Health 101, if you'd indulge me, because language is important. Sometimes you hear colleagues say there are health disparities. And what do we mean by health disparities? Well, that simply means that there are differences. Differences, that's all it describes. Differences in the numbers of cases that you see between one group or another. The reason we talk about health equity is that we bring the principles of social justice to the differences which you observe. And that means that we're looking and talking about issues of fairness. We're understanding that everybody isn't starting at the same level in society, and therefore some people may need more help to get to that place of equality than others. It means that we have very different discussions on why these differences are occurring and therefore how we address them. And it means that when you look through the lens of equity, that everything you do must change, because when we know better, we do better. So, are you ready for me to start the lecture? What I wanted to do this morning is really just to take a short canter back on the journey over the last 3 years. And many of you will be familiar with this because you've been part of this journey as well. The bold announcement in 2019 that the government was committed to ending HIV transmission by 2030 set the pace and the tone that we needed to turbocharge our HIV prevention efforts. And following that commitment with a new HIV action plan has been a key part of ensuring coordination, ensuring new funding, ensuring new energy as we approach the declining trends of HIV in the United Kingdom and specifically in England. Now, bold targets are easy to say. What is much harder is to ensure that the funding follows the narrative, that the work gets done, and that as we're doing this work, we're having that laser-like focus on equity. And this has been a key part of how we've approached the work that we've been doing, because we are in a declining phase of HIV in the United Kingdom at this stage. And when epidemics decline, there are a number of things that you need to be aware of. Epidemiologically, it means that we're seeing lower and lower numbers of cases occurring, and oftentimes those cases become more and more geographically concentrated. So there are going to be more parts of the United Kingdom as we approach 2030 that won't be seeing any HIV cases because numbers are coming down. It also means that as the numbers begin to decline, the people who continue to become HIV infected or living with HIV are people who are more likely to be socially or economically marginalized or excluded. They're going to be people who have poor access to healthcare services and to preventive services. They may well be in geographic areas or settings or with risk behaviors which may place them at increased risk. And epidemiologically, the people who are much more likely to acquire HIV as we approach elimination are much more likely to have more complex lives as they look at the intersection of alcohol, drug use, mental health issues, high-risk behaviors. So the nature of the epidemic will change and as we approach the elimination of HIV transmission. So the key summary here is, as we approach 2030, the job will become more difficult because the epidemic is changing. Now, this will have huge implications for what we do as we approach 2030. It means that our programs are going to have to change, right? Because the nature of who's acquiring HIV is changing, and as the minister says, ensuring that the focus on equity, the focus on stigma, tackling discrimination, engaging communities, partnering with communities becomes even more important. And policy will need to change as well as we approach 2030. It means that we have to have very honest conversations about what's driving HIV transmission and who's getting infected. We're going to have very different conversations about stigma and discrimination and racism and poor access to services and marginalized communities and inclusion health. It means that the way we deliver services have to also change as well, because we need to now bring the community closer to us in statutory services in order to develop the services that our communities need. Again, with this slide, there's a lot that you can say in a picture, but what I wanted to drive home is the epidemic that we're dealing with today will change, and with it, we must also change our response. And that is why I'm so excited about the Minister's announcement and the commitment to a new HIV action plan. Now, the current HIV action plan, as many of you know, had 4 key pillars, and I'm highlighting a number of them here. The first is around the equitable access of HIV prevention programs, and this must continue to be a key part of our work moving forward. You have seen the tremendous progress that we've made on PrEP access, on scaling up HIV testing, and continuing to work with our local authority colleagues to fund HIV prevention programs, even in some of the most challenging economic times. The Minister has already reflected on HIV testing efforts and the importance of scaling those efforts to ensure that we continue to reduce the undiagnosed fraction of people living with HIV within England at this time. We've been doing a lot of work over the past 3 years on optimizing access to treatment. And today we're having very different conversations about retention in care, maintaining people in high quality care, and innovating and looking at the importance of peer support workers embedded in HIV treatment centers as a key strategy of encouraging and engaging people in their HIV care. Phenomenal work that you are all doing to ensure that not only are we testing and linking to care, but keeping people in care as well. And we've also committed to improving the quality of life of people living with HIV, and that's been a core part of our work. And there's so much innovation happening across the country. In London, the work on an HIV charter, the work on thinking about HIV champions, speaking about stigma and encouraging and educating about HIV in the 21st century. So the HIV Action Plan has enabled us to focus, to deliver programs, to scale programs, and to drive forward. But the journey to 2025 and to 2030 will require us to build on this success and to ensure that we incorporate the learnings of the past few years. So in the next few slides, what I wanted to cover very briefly were some of the contextual issues that we need to be aware of as we think about 2030. First, that the patterns of the decline in HIV are not happening equally across the country, and we're likely to see significant changes between the pattern here in London and the patterns outside of London as well. Second, as we are going through the decline phase of HIV, keeping a close eye on new communities, new populations who might become living with HIV or might be affected by HIV transmission, and ensuring that we have data that enables us almost in not real time, but in a timely way to identify new and emerging populations will be key. We need to ensure that we are continuing to work on increasing access to care and ensuring that that time of linkage to care from diagnosis to receiving antiretroviral therapy continues to increase. And this has been a success story for us in England, and we will commit to continuing to do that. And finally, as you've heard from the Minister, we have phenomenal levels of viral suppression in England, and we will continue to look at our data, interrogate the validity and reliability of that data so that where we need to make corrections, we are able to do so. Understanding that viral suppression will vary by age, by gender, by where you are in the country, and so therefore our strategies to ensure viral suppression will be key. Now, context is going to matter as we move towards 2030, and here are some of the things that I know you have all been grappling with. In a post-pandemic world, when there are so many pressures that we're grappling with, how do we create the space to focus on HIV prevention and reproductive and sexual health and keep the momentum on what needs to be done? How do we ensure that in an environment of a cost of living crisis, rising inflation, that the funding that is required for scaling our prevention efforts exist and are used in the most effective way? How do we deal with populations that are more likely to be socially and economically disadvantaged as we move towards 2030? Do we have the programs for social care? Do we have the programs that integrate mental health care for people who are living with HIV? And finally, how do we ensure that in the context of changes in sexual health, we continue to have that focus on HIV prevention? And this last issue of the context of sexual health is critically important because we know that STIs facilitate the transmission of HIV. Now, the data are clear that what we're seeing across the country is a resurgence, especially of bacterial STIs. And this will require new ways of thinking about tackling those STIs, looking at new prevention technologies, but integrating our HIV prevention efforts as well. And this is particularly so for gay and bisexual men, where we do see a disproportionately high burden among some of the STIs. And therefore, how we begin to think about prevention efforts for HIV and STIs holistically will be critical. Finally, what I wanted to end on was just reflecting on keys to success as we approach 2030. And I think there are a few things in terms of emerging best and promising practice from the first 3 years of the HIV Action Plan that we will certainly be bringing towards our work moving forward. First is the importance of strong leadership and cross-sector collaboration and coordination for the HIV response. Across the country, there's so many fantastic examples of where coordination is taking place, whether at the national level through the HIV Action Plan Implementation Steering Group, whether it is in localities across the country with the Fast Track Cities program, or whether it is commissioners coming together to think more holistically about commissioning for services. It is crucial that for the new HIV Action Plan that we embed coordination and cross-working between the NHS, local government, communities, and others for success. We know this is necessary, and we know it works, and it would be important for us to embed this. Second, new technologies are going to be critical in our journey towards ending HIV, and we need to ensure that we are realigning our investments and investing in and spending in the right places to have the impact. And we have seen some of the amazing work that we've been doing on reprioritizing spending and the impact that that has had. This example is of the HIV and bloodborne virus opt-out testing program, which, as we've heard from the Minister, has been critical in uncovering undiagnosed HIV infections. The early data are presented here, but you will see throughout the course of the conference today other presentations on more recent data on just how powerful this intervention has been. But this is just one example of new approaches to testing and linkage to care. And a key part of the discipline of the next 5 years will be looking at new approaches. Third, we must prioritize prevention and promotion of health, and we must think about this in a holistic way because the issues of health equity are critical. And again, they've been great examples by work you're doing in places across the country of where we're looking at health promotion and applying a much more equitable lens. In London, we have our HIV prevention program and our Do It London HIV campaign. Around the country, you are using resources in innovative ways to continue to speak about HIV. And this is going to be critical, that cultural competence of our prevention efforts as a key part of what we do. Finally, and most importantly, as we move towards 2030, we must deepen the work that we're doing on community-centered approaches, on cultural competence, and really looking at asset-based approaches to preventing HIV. And that will be certainly a commitment from myself as we develop the HIV Action Plan, that the voices, the experience, and the wisdom of communities are integrated into that work. So whether it is the work on the Fast Track Cities program, or again, other examples from across the country, bringing communities in to be a part of co-producing solutions will be a critical part of what we need to do. So colleagues, thank you for your work. Thank you for your passion, and thank you for being with us and helping us on this journey towards 2030. I hope that in the presentation that you've seen today, you too understand that what has gotten us to this place today will not necessarily be what will get us to 2030. We will need new approaches. We will need to bring communities closer to us. We will need to have open and honest conversations about equity, about discrimination, about marginalization, sometimes difficult conversations for us to have. But we are a part of the HIV community, and we are used to having difficult conversations. That's what got us here. Thank you.
That was remarkable and excellent, Kevin. Thank you so much, and we can see why we've been making the progress we have under your leadership of the action plan, and long may that continue. So next I'm going to introduce Memory, and Memory, you'll know, is a HIV advocate, but crucially the coordinator of UK CAB's advisory board. She speaks with passion and determination about not just HIV and her experiences, but others, and particularly the experience of women living with HIV. And we're so pleased to have Memory Sachikonye with us today. Over to you.
Good morning, everybody. I'm very nervous. Okay, so I'm here. 22 years ago, I was diagnosed with HIV with a CD4 of about 6. I was visiting the UK on a family wedding. My aunt was getting married. Back home, I was the manager of, I was an IT manager for a regional NGO that dealt with the development issues in Southern Africa. So the UK was not my first visit. I have a large family here, so I'd been coming to the UK for a lot before that. So this visit was just one of those visits. Christmas, my aunt was getting married on the 21st of December. So I left my car parked at work. My son was going to mid-year secondary school. He was 15. I left my brother to sort out his school fees for January because I was going to go back after the schools had closed. So after the celebrations of the wedding, Christmas, I didn't feel well. And my aunt recommended that I do get a test, just an HIV test, to get that out of the way. So straight after New Year, I went to a local gum clinic, had the test, didn't think much about it. You had to go back the following day to go and get your result. 24 hours later, I went back, and everything just fell apart, being told I was HIV positive. It is, up to this day, a blur of what I was told after that. Luckily enough, I had 2 people with me, and I was just told to wait in reception while they wrote a letter to go to the nearest hospital, which is the North Middlesex Hospital, where I'm a patient now. So getting to the hospital, I had no idea how to navigate the health system. I didn't know anything about HIV. I didn't know about AIDS, not HIV, just because I'd lost 5 family members, my uncle, his wife, and 3 cousins in the space of 1 year. So I was aware we're losing work colleagues that were at work as well. Somebody doesn't come to work for a week, next thing you're going to bury them. So it was very tough in Zimbabwe, and there was no treatment. Having done that, I was referred to go to a support group, a peer support group at Positively Women, which is now Positively UK. So walking in there and seeing all these women being jovial and just laughing and chatting, and I'm thinking, do they have what I have? But anyway, I met a very lovely support worker, a caseworker, who was looking so glamorous, telling me that she has lived with HIV for 17 years. I looked at her and felt, and that's when I thought, okay, I need to do this, I can do this, I need to live. I jumped into volunteering and became part of the editorial team of the magazine that was going to women nationally. Within 3 months, I was so empowered and had gained some self-esteem. I put myself on the cover of that magazine, just telling my story about asylum seekers. Of course, in the background, there's immigration coming. I was here on a 6-month visitor's visa. So with the support from the organization, I managed to get a lawyer. Those days, they were quite available, and it was a lawyer who was doing it for free, and for freelance, not freelance, but for free. So she did work very hard, and 6.5 years later, I got my stay as a refugee, which means I still couldn't go home. So my son was there at home, going to see him, was just talking to him. My family did support to get him through school. And the first job that came about was the UK CAP position at HIV iBase. I applied for that job. I had no knowledge of treatment. You go to the hospital, having to understand what medication you are being given or what's being said was, of course, Greek to me. I managed to learn from not identifying pills as the orange one and the blue one to the actual names. I was determined as well to speak out and make sure that other people like me, who are women or whoever they are, do not go through that phase of being hidden and not showing that you can actually live well with HIV. So, of course, I was, from my diagnosis of 6 CD4, I had a lot of opportunistic infections. So first, I was told that I had a kidney disease, which I didn't know I had, but then it does run in my father's side of the family. So that went quiet for a while because I was just going through other problems. I was lucky enough to get a transplant in 2015 from a cousin, and I'm here today thriving. However, in February this year, cancer had to come by, so I was diagnosed with breast cancer in February this year. It was an early diagnosis, all under it's managed well, done my radiotherapy. I'm well. So throughout this whole difficult journey, there's something called support. You find people that you get on with. There are organizations that give you support. And having been to so many support groups, I was coordinating another support group in Enfield where I live for Black African and Caribbean people. But you get kind of worn out by the basic support group. It's still helpful for other people. So there were 4 other women who became close friends. And then we started our own journey, like just having a support group of 5 40-something-year-old women. We are now in our 50s. And we just thought, what do we do with all this knowledge and expertise and experiences we have had? So when it came to the 40th anniversary of the discovery of the AIDS virus, we decided to write a book. There's 5 of us, the co-authors, who are named Angelina Namiba, Winnie Seruma, Rebecca Mbewe, and Charity Miranda. So we sat down and thought, we need 40 stories to get people to understand how us as the Black community have contributed to the HIV movement in the UK. So we got our allies, who are our doctors. We have Professor Kevin Fenton, who also contributed to the book. And a lot of other people did contribute. And the book is now out. It's called Our Stories Told by Us, and it's available on Amazon. With the UK CAB, it's an organization that is an activist organization for treatment. It has that unique thing about just focusing on treatment. We do work with all the other HIV organizations, and we look at people as individuals. So it's the voice of the community in terms of being representatives in clinical trials, in clinical sharing. We have representation with the British HIV Association, BIVA. I'm a representative on several studies, and the main one that I'm still on is now the POPI study on aging, HIV and aging. We meet with the pharma to kind of understand what they are doing, question them on their new drugs, and just stay up to date with the latest progress in treatment. Looking at women, I'm a woman, so I have to advocate for women. I was reviewing the key findings of a study that was done in 2018 with Sophia Forum. There's a publication online. It's called Women and HIV, Invisible No Longer. This was 2018. And looking at the inequalities then, which are still not addressed today, which is a bit worrying. I will not go through the inequalities, but I'll just talk about, what can we do as we approach 2030 in the few years that we have left to try and make sure that we are all on the same page. Of course, we still need universal access to consistent HIV treatment for everyone globally. We still need our peer support. With the new opt-out system in A&E, every time I come across somebody who's telling their story or who has just been newly diagnosed, I am still very touched. Everybody has a story to tell. And without that peer support, some people cannot get through just accepting that they have HIV and therefore being able to stay in treatment and take their medication correctly so that they do not pass on the virus. Stigma is still a big thing. Wherever you go, there's stigma. But stigma does kill. People disengage from care, which is another big problem within the HIV community, or because they can't be identified in their community, in their church, or by their family that they are taking HIV medication. Yet the risks of not taking HIV medication are far greater than the stigma for me. What can they do to me if they know I'm taking HIV medication? At least I'm in control of my health. And I know that I'll not be able to pass the virus to anyone else. We also need the tailored support services. We are aging. I'm 58 with multiple morbidities. I say to people that every body part of mine is a consultant, and that's not a lie. How do I link up all those appointments, consultant? I have to take a letter every time with the list of medications that I take, with all the diagnoses that I've had and all the treatments that I'm going through to just make somebody else understand. Can I just have one thing where somebody puts my NHS number and all this information comes up? So, of course, the theme of this conference is prevention of new infections. Women still struggle to access PrEP, and the biggest highlight of the AIDS conference in Munich this year was lenacapavir. When are we going to get it? It works. It has shown that it works in not acquiring new HIV transmission. It's there, but it's not accessible. So what are we going to do in the UK, in England, and globally to end these new infections? We still struggle, and we need to focus on the vulnerable communities like trans women, women who are in very difficult abusive relationships, and women in conflict zones. We want to be involved in decisions that are being made for us. These are the Denver principles from way back. We want to be we want to be literate. The UK CAP does a lot of activist training where we can understand research, being able to see that if they say 75% of this cream reduces your wrinkles, okay, it was only on 73 people. How does that work? So we need to have that literacy to understand when research is being done, a new drug is developed, only to find that there were 6 women in the trial. We are women. We have different, our biology is different to men. We are taking the same drugs that have only been tested on men and very few women. We are menopausal. My bones are weak. Everything else on me is changing. How can I still not be able to know that I'm taking this drug, it's not going to have long-term effect on my bones or just my mental well-being? Mental health services are still a big issue. As we age, of course, I have brain fog a lot. I meet people and I'm like, oh, hi, but I can't remember their name. I still smile. The minister did talk about focus on quality of life. I think that's very important. We all need to live well, not just, we are something else beyond being undetectable. Yes, I'm undetectable, but I also need a good quality of life. I need to be able to access services when I need them. I need to be able to access physiotherapy, for example, if my shoulder hurts because I'm developing arthritis. And so I think there's quite important things there. We also need to focus on equity. These efforts to end AIDS in 2030, in the 5 years and 3 months that we have left, are a priority. And we need everybody to be involved so we can all have the same access to good health, we all need access to good health and equal opportunities in our treatments. We still need investment in ensuring that services continue to run to support people living with HIV. I said earlier, I'm getting to be an old woman, and aging with HIV has its own problems. We have too many conditions, and we're starting to think of care homes. Is our health system robust enough to accommodate our new needs as we age? We are the first generation to be aging with HIV, and I leave that question to the Minister. Thank you.
When Memory's speaking, always prepared to be upstage. Isn't she amazing? What a fabulous advocate for our cause and for people living with HIV and women living with HIV. We've had amazing speakers to start our day, and I hope you enjoy the rest of the conference today going forward. There's a number of sessions throughout the day, and I would like to point out to you that Gilead, our very generous key sponsors, have Kevin Fenton on the panel as well as other people. So if you wish to see Kevin's great persuasive skills again, you've got another session that you can seek out during the conference. And we've got a little break now, so you've got till 10:50 for the next session. And if you go through, there is, you'll see around that people in the HPE T-shirts will direct you in the right way. There is a quiet room available for people, there is a prayer room for people, there is poster displays throughout the conference, and there are different toilets, including gender-neutral toilets, if people prefer to use them. I hope you've really enjoyed this first session. Please join me again in thanking Memory, Kevin, and Andrew Gwynne for being here today and starting us off so good.